Hi, I'm Hannah Bautista, and I'm doing my presentation on retinoblastoma. So retinoblastoma is a malignant tumor of the retina. It's caused by mutations in the RB1 gene located on the 13th chromosome. So RB1 encodes the protein retinoblastoma protein, or PRB. It acts as a tumor suppressor, and PRB prevents excess cell division, but when it's mutated, there's uncontrolled cell growth that forms retinoblastoma tumors. There's a two-hit hypothesis, which means that both copies of the RB1 gene need to be affected, one from each parent. The first is an inherited mutation in one RB1 allele, either inherited or spontaneous. So you can see that in the pedigree chart from the affected parent and the non-affected parent. And then the second hit is a loss or a mutation of the RB1, of the second RB1 allele. There's two types of genetic causes for retinoblastoma. First is inherited. It's a mutation of the RB1 gene. It's an autosomal dominant inheritance pattern, which means the child only needs one copy of the mutated gene. And then it shows up as bilateral, which means tumors in both of the eyes. It's early onset, which means before the age of 1, and it's probably and that's the most common one. And then you have sporadic retinoblastoma, which has de novo mutations of the RB1 gene. And de novo means that the mutation happens spontaneously, not inherited, so just randomly. And that shows up unilaterally in one eye. So some demographics on retinoblastoma. About 80% of the patients are diagnosed before the age of 3, so it shows up in a lot of younger children mostly. And then 3.7 per million are under the age of 15. And then around the world, there's about 9,000 children that are diagnosed every year. And by country, socioeconomically, middle-income countries are about 69% of the cases, low-income countries are 20%, and high-income countries are 11%. And then 70 to 75% are unilateral and sporadic retinoblastoma, and then 25% are bilateral and inherited. So this is a healthy eye and an eye affected by retinoblastoma. The retina is the yellow part in the back of the eye, and then on the left picture you can see on the retinoblastoma that's where the cancer and the tumor grows. So in the front of the eye, or around the eye, you have the sclera. It's the white part, and it protects the structures of the eye. And then in the front is the cornea. It's the curved window that protects the eye and bends light rays. And then you have the iris, which is in the front also. It's the colored part of the eye, and it regulates the pupil. It dilates and constricts depending on the light. And then you have the lens, which is kind of the front middle part. The muscles curve, the ciliary muscles curve and flatten the eye. So this is how you can determine if you're nearsighted or farsighted. And yeah, it maintains the shape of the eyeball. Then you have two types of humors in the eye, the aqueous humor. It cleanses and nourishes the cornea, and it maintains eye pressure. Then you have vitreous humor, which is all the red stuff. It's a jelly-like substance, and it fills up most of the volume of the eye. And then finally, in the back of the eye, the yellow part is the retina. It's sheets of photoreceptors in the innermost layer, and then you can't see it in the picture, but in the back, it's the optic nerve. It's the cranial nerve that connects to the brain, and it tells you what you're seeing through your eyeball. So physiology and symptoms of retinoblastoma pictured are the two most common, leukocoria and strabismus. Leukocoria shows when you flash a light or you take flash photography and there's a white part in the eye. It's also called a cat eye reflex. It's the most common symptom. And then you have the second one, strabismus. It means your eyes cross. You can have esotropia, which is crossing inward, or exotropia, crossing outward. or the other types as well. And that's when the tumors are affecting the muscles that control which direction like your eye is facing. So if you have poor control, you can get cross-eyed. Other problems are vision problems. You can get loss in the central part or the peripheral part of your vision. You can get inflammation, so bloodshot eyes or blood in the eyes. You can get glaucoma, which is increased eye pressure, which can cause some pain. Tumors prevent the drainage of the eye, which can cause an increase in intraocular pressure, and the eyeballs can become bulged, which is pretty uncomfortable. Then you can have vitreous seeding, and then seeding means like little parts of the tumor can spread throughout the eye. And then patients can notice like little floating spots or cloudy vision. You can also get a detached retina, which can cause blurred vision or complete vision loss, light sensitivity, or nystagmus, which is involuntary eye movement, when your eye kind of shakes a little bit and like kind of looks like vibrating or looking from side to side. And then you can also get exophthalmos, which is protruding of the eye or bulging of the eye caused by inflammation or fluid buildup. So this can present as like super wide eyes with the eyeballs popping out a lot. So physiology and diagnosis. There's a couple systems that retinoblastoma uses. This 1 to 4, International Retinoblastoma Staging System, IRSS. So it tells the like advancement of it. So 0, you're okay, and then 4, it's spread to not only the eye but different parts of the body through the central nervous system or the lymphatic system. And then the International Intraocular Retinoblastoma Classification, IIRC, and then the Intraocular Classification of Retinoblastoma, ICRB. The ICRB tells the location and the size of the tumor, and then the IIRC on the right side of the column tells a little bit more information on that. And these classifications are used to determine what kind of treatment you have. So group A, you have a low risk. It's confined just to the retina and very small, not close to the optic nerve, no seeding, or spread to the other parts of the eye. So that's kind of group A and B. And then group C, you have seeding, which means it spreads to the humors or the different parts of the eyeball. So it's not just in the back, and it's maybe a little bigger or closer to the optic nerve, which can still be treated. And then group D and E, which means that these are high risk, and either the seeding is very large or it's spread to many parts of the eye. These cause kind of irreversible damage. Let me move my face, you can see. And then there's damage to over 50% of the globe, and a lot of hemorrhaging in the eye and further damage, which you would need enucleation, which means like surgical removal of the eye. Next. And so once you have your tumor classified, unilateral or bilateral or A through E, we can look at treatment. So in the top of the tree, we have unilateral, A and B. We can use cryotherapy, and cryotherapy uses extreme cold to freeze and destroy small retinal tumors at the peripheral of the retina, not in the middle. And it uses a cryoprobe applied directly to the affected area. And then you can also use transpupillary thermotherapy, or TTT. This uses infrared laser energy to heat and destroy the tumors. It doesn't penetrate the eye directly, but uses lasers to pass through the pupil. That's also related is laser photocoagulation. It's also laser therapy. So A and B can use either of those. But then B, you can use intra-arterial chemotherapy, or IAC, for about 3 to 4 cycles. It's chemotherapy that's used on the ophthalmic artery that supplies the eye. Advantages of IAC include limited side effects, so that can mean vision preservation. So categories C through E also use IAC for a couple cycles. If you have bilateral retinoblastoma, you can use intravenous chemotherapy for about 6 cycles. And then these chemotherapies are called vincristine, carboplatin, and etoposide. So they're used bilaterally, and they're used for tumors that are difficult to remove with surgery. So you get your treatment, and then you get a follow-up kind of every 4 weeks, and then you either improve or the tumor stabilizes, or you don't get any better and it's failing. You need global salvage. This means that you need enucleation, and enucleation is a surgical removal of the affected eye. So you take out the entire thing. And this is used to when the tumor has metastasized to the optic nerve, or when vision's not able to be saved. And so you take out the entire eyeball to prevent the cancer from spreading, not only to the eye, but to different parts of the body. And the patient is able to get cosmetics or a prosthetic eye for cosmetic purposes. But there's a 3-year survival rate for unilateral and bilateral retinoblastoma, close to 96%, which is pretty good. AI is being used, or can be used, for retinoblastoma. There's a couple programs that are being used called LIME, LIME, and SHAP, SHAP. So data is analyzed from 400 retinoblastoma and 400 normal fundus images of the eye, and then they diagnose and differentiate from retinoblastoma and non-retinoblastoma. So it can look at the photo of the eye, and it can find the tumors and tell you if you have some growths there or not. Some benefits of this are that you can analyze a large amount of data. That's like 800 images, and AI is able to do that. Because typical diagnosis, it relies on the awareness and proactivity of the parents and caregivers and professionals. So if you notice that your child is having some symptoms like the leukocoria or something like that, but people are not able to see the small tumors or deep tumors or early stage tumors that AI can use, and it enhances accuracy, efficiency, and accessibility. AI also uses like non-invasive methods, just taking a photo of the eye, and it can distinguish between malignant and non-malignant tumors. It can also help the medical professionals with the development of the disease and the effectiveness of therapies that they're getting. Some limitations would include cost effectiveness and trustworthiness. So cost effective meaning that obtaining the eye imagery is like kind of expensive, and also training staff that are specialized in taking pictures of the eye and analyzing the data is also expensive, especially in areas with low resources. Also that more diverse and broader spectrum of cases can affect the algorithm, and rare cases of retinoblastoma can also obscure data. And then in the studies, it said that to combat these limitations, we can advance mobile and portable imaging devices and improve AI algorithms to include the more rare cases or the skewed cases. Thank you. There's the references. Thanks.